Good day, colleagues, and welcome to our October ECHO session. I'm delighted to be your moderator today. My name is Francis Ochen. I work for the ASLM team, and I'm very, very excited to be your host today. Today's session is co-hosted by myself and my colleague that I will be introducing very shortly. This is a 1 hour long session, and we have language interpretation, and we encourage you to choose the language of your choice. If you're French speaking, please choose French, and if you're English speaking, choose the English language so that you get all translations in real time. We also implore you to join the discussion through our chat room, and there will be real-time response to some of the questions and comments that you will be making. And then at the end of it, we'll be wrapping up. This session is one very important session. We'll be focusing on screening for latent TB infection in resource-limited setting, and the need for innovative solutions to meet the EndTB strategy. We are all aware that achieving the EndTB strategy requires bridging gaps in existing TB care cascade, but also implementing latent TB infection screening in high-risk population. We know that active cases will come, a significant number will always come from the latent infection that we have, should the criteria for causation be met. This session again will also focus on the basics of latent TB infection, the critical importance of screening for latent TB, in addition to active TB case finding, and we will have experts discussing with us the gaps in the current TB care cascade, and then considering various options for latent TB screening, and then highlighting, of course, the benefits of test and treat approaches, including interferon-gamma release assays. Colleagues, joining me today and my co-moderator and our first speaker is going to be Giorgio Racino. Racino will be addressing the gaps, will be presenting a session on addressing the gaps in current TB care cascade through the implementation of screening for latent TB in high-risk population. Now, Dr. Giorgio is a medical doctor and a senior executive with vast international experience in large pharmaceutical companies and a broad experience in the public and private sector with a mix of both drug and diagnostic development. He worked for 20 years with major pharmaceutical companies, including Aventis. He's also developed all TB drug fixed dose combinations containing rifampicin. He led the clinical development to regulatory approval of the first non-toxic drug for the treatment of trypanosomiasis. And he was among the founding members and first CEO of Global Alliance for TB Drug Development, and also a co-founder and a first CEO for FIND, Foundation for Innovative New Diagnostics. And during his tenure, Giorgio led the approval of 5 diagnostic devices, including the widely used GeneXpert that we are now using both for TB and other infectious diseases. He subsequently joined ASLM, and I'm proudly mentioning this, among the leadership team, and he was our Chief Operation Officer based in Addis some time back. And in 2015, he founded the Next Foundation in Geneva and the Next to People with offices in Addis Ababa. He is currently the chair of the Next to People. I'm glad to then now introduce you, Giorgio, to take over from here. Very welcome, Giorgio.
Thank you very much, Francis. I will just go ahead with my presentation, and I will hopefully be able to share my screen properly as I've been instructed. Yeah. you very much, Francis, and thank you, the ASLM, for organizing this very important eco session, which is really part of your divulgative and effort for African countries. And I am very excited to talk about latent infection, which has been really a little bit the forgotten brother in the TB world, as it were. So the most important thing about latent infection is that latent infection is, as defined by WHO, a state of persistent immune response to stimulation by Mycobacterium tuberculosis antigen with no evidence of clinically manifest active TB. What is important to remember is that up to 1/3 of the world population is estimated to be infected with MTB, and the vast majority have no sign or symptoms of the disease, are not infectious, but they, although they are at risk of developing TB disease. 5 to 10% of those infected with Mycobacterium tuberculosis will develop active TB during the course of their life, usually within 5 years after infection. The risk for active disease after infection depends on multiple factors, yet the most important being the immunological status, HIV, and age. As you can see from this slide, you can have a primary infection and then have, which is a primary infection, and then you can be reinfected during the course of your life. You can develop after the primary infection a primary disease, and then you can still develop the disease due to endogenous reactivation, which means what I just described about the fact that your immune system is not capable of containing anymore the primary infection that you have developed at the beginning, or it can be due to an exogenous reinfection, which is following contact with the active TB patient. So the progression from latent to active TB is, as you can see from this slide, you have the infection. The infection can be eliminated even immediately somehow at the very beginning. Oh, sorry. It can be eliminated, and it could develop into a primary TB infection. And then you have this lifespan where you can have a rapid reactivation of your infection, or you can develop what is called a cyclic disease over time, which can stay as it is, and or you can also have moving from that state moving into active TB. So it's that's how normally it works out. Now, when we look at the vision for TB elimination by WHO, and we can see how our current global trend is moving, and in the decreasing of TB cases per year, as you can see, we are currently at 1.5% per year, which is quite a very low rate. But we expect that by 2025, with the optimization of the current and new tools that might emerging, but by 2025, the hope has been that we might have a vaccine, or we might have new drugs or new treatment regimen, possibly shorter than the current 6 months. The 4 months is being now currently evaluated and probably recommended by WHO very soon. And also to have a better tool for TB infection screening and TB infection treatment. So this is by 2025. So if we look at all this happening in 2025, with all those new tools coming into the picture, then we might expect that by 2035, we could reach a stage where we can reduce the TB by 17% per year, which would take us very near to the TB elimination. On the other slide, on the second part of this slide, you can see how the baseline is now, and this most related to deaths and how different implementation attitude or technologies do affect that baseline. So to reach to the EndTB strategy by 2035, which means to reduce by 90% by 2035, you can see that if we mitigate the risk factors, there is a slow decline for sure. If we are capable of just prevent the infection and treat active TB, then we are doing also a better job. But if we treat latent TB infection, which is a possible reservoir of active TB, and if we do the both things together, which is treat latent TB and treat active TB, that's the latest curve that takes us to 2050 with a very low rate of TB. So now when we look at individuals with LTBI, with latent TB infection, as we said, are asymptomatic, but they constitute an important reservoir that can contribute to the pool of active TB in the future. As we have seen, up to 5 to 10% might develop the disease over time. As the success of global TB control will heavily depend upon the performance of TB control program in high TB burden countries, of which many are in fact in Africa, it is very important that we look at the possibility of treating LTBI individuals along with active TB. So combining the treatment of active TB with the treatment of latent TB. Now, there has been a lot of discussion over the possibility of having mass population screening and treatment for everyone, or at least for all those that are infected. This is very difficult to implement, it's not very feasible, and that's why what is recommended now is that this approach should be, in fact, limited to the risk population that have a risk for progressing significantly into active TB, and in which we can balance the benefits that should exceed the potential harm, like drug adverse events. As you know, we now have rifampicin plus INH, and we have to be very careful to exclude active TB in order to prevent the emergence of TB resistance in those that are TB infected and that are going through the treatment of latent TB infection. And then obviously the cost of all this has to be taken into account. Now, when we look at WHO recommendation for consolidated guidelines or who are the risk group in TB detection, now, and you categorize this by different groups, like disease progression. You have, of course, the HIV, the immunosuppressive therapy, renal disease, children under 5, silicosis, pregnant women. And TB infection transmission is really very important here, because that's where there might be a potential to expand the possibility of screening, active screening for TB infection in this group of people, where the transmission of TB is quite high. And this would include healthcare workers, immigrants from high TB burden country, prisoner, homeless, military, all contacts of active TB, and we'll come to that a little bit later on, and MDR TB contacts. Then, of course, there are cumulative risks which are associated with diabetes, alcohol abuser, tobacco use. We all know the association between TB and diabetes, malnourishment, and then the traveling that has been very much associated with the diffusion of MDR TB from some of the high endemic countries for MDR TB up to the United States, which made big news some time ago. Now, the management of LTBI, according to WHO, preventive treatment of infected people with LTBI is recommended absolutely for people living with HIV or people taking anti-suppressive drugs, immunosuppressive drug, recent contacts of pulmonary TB of all ages, immunodeficiencies due to organ transplant, renal dialysis, silicosis, which is a very important comorbidity, particularly in the Southern African part of our continent. And then screening and treatment. This is that preventive treatment, and the screening and treatment for LTBI, according to WHO, is optional for healthcare worker exposed to TB, migrants from high incidence country, prisoner, homeless, and user of illicit drugs. Now, this is the current algorithm that is being recommended for HIV positive, for household contact, and other risk groups. So what is that should be the approach in screening and then treating for LTBI? So when we look at household contact, the question is whether is that household contact of a sputum positive or a bacteriological positive patient, is it symptomatic? If the answer is yes, then he should be investigated for active TB. If the answer is no, that is not symptomatic, then if it's less than 5 years, then preventive treatment, and particularly in HIV positive patient, is recommended. And then if it's more than 5 years, the recommendation is to test and to screen those people with the TST or IGRA. I will go into the details of these two different tests, but one is the tuberculin test and one is the IGRA test. So if these are negative, then it's all right, don't do anything. But if they are positive, then that's where the next step comes in, because if somebody is infected or comes out to be positive at that test and demonstrating that he's infected, then at this time we need to exclude active TB before giving him treatment with rifampicin INH, which are drugs that are used for the treatment of TB. Now, the potential risk is that by not being good at treatment, following the treatment and supervised treatment for these drugs and having irregular intake of this drug, this might lead into emergence of drug resistance, which in the case of rifampicin would be quite an important thing. So that if the X-ray is normal, then if the X-ray is abnormal, the patient should be investigated for active TB with gene expert or something else. Or if it is normal, then he should go into treatment for active TB, for LTBI treatment. So this is now the case of the two tests that we've just said. One is IGRA and one is the tuberculin skin test. The IGRA test, which we'll go a little bit more into details later on, but is characterized by the fact that you need a single patient visit to conduct the test. So the patient himself doesn't have to come back to the clinic, but the results will still need 24 hours because it goes through a process that is, well, most of you are laboratory technicians, so you would very clearly understand that is an ELISA test, so it requires a little bit multiple step, let's say, procedure, and it will need to be in a proper laboratory. But what is important about the IGRA is that does not boost response measured by subsequent tests. And the most important even is that the BCG vaccination does not cause a false positive IGRA test results, because let's not forget both of these are immunological tests, the TST and also the IGRA test. But because there is a immunological response to BCG, that doesn't interfere to the results with the IGRA test. So, and then current recommendation for IGRA is that should be preferred for testing in person that has been vaccinated with BCG, which is the majority of the people in many African countries, and person that have poor rates of return for TST reading. Why is that? Because the tuberculin test is using a small needle, is a skin test, which is done using a small needle, and the healthcare provider, even at a very low level of the health system, injects a liquid, the tuberculin, into the skin. When injected, there will be a pale bump will appear. Now, the person that has been injected with the tuberculin needs to come back to the clinic 2 or 3 days after, and then a trained healthcare worker will measure the result, the reaction on the arm to understand whether it is positive or negative. So it's a little bit a very subjective test because it requires very well trained people, and but it has it can be done, and it requires always the patient to come at least twice to the health facility. There is some important things relative to TST, that missing infected people with negative screening tests, and this is particularly immunocompromised patient may have a negative test despite the infection with TB, of over-treating also uninfected person with a positive false positive screening, and large proportion of positive screening are not confirmed by IGRA test. So what are the drawbacks of both these tests? You know, the first thing about the TST, the tuberculin skin test, there is problem in availability in countries. It has been widely available until probably 7 or 8 years ago. Since the production has been moved to different countries and to a different company, the problem of dispatching and availability of the TST test has been a major problem. There's been also a problem with the quality control of the tuberculin itself. And then, as we have just seen, there is an interference with the BCG vaccination, and then it requires 2 visits of the patients. Now, these are important programmatic and logistical drawback relative to the TST, which has in fact limited also the thinking about using more screening in other at-risk groups. So, and there is currently no other alternative to the current tuberculin skin tests in places without access to laboratories. And then the global shortage of tuberculin remains a very ongoing problem. And then the Quantiferon, the current Quantiferon, the IGRA test, now of course, ideally solar or battery, if that is the case, it should be able to detect TB infection, which is important, and also active TB in any at-risk population, and should not require a highly trained technician or a laboratory, but most importantly, whatever it is, that point of care test should be linked to follow-up care and treatment. So I just put down here a sort of a pyramid which we used in the past to look at how the different level of the health system and how do we include different technologies. So on the left-hand side, you can see that we have, first of all, at community level, that's what you are looking for market exposure, contact tracing for TB patients, surveillance, and early diagnosis. These are the 3 or 4 key issues that you would want to see at community level. And currently we have IGRA in terms of possibly collecting the blood from the patient, from the community healthcare workers, and the TST. The TST certainly can be performed at that level. In the future, on the right-hand side is what might happen at that level, which is now GAIA Reach, which is the new technology that we are going to hear briefly. The LAM test, as you know, this is also a very important lateral flow technology, a rapid diagnostic test, which has been used in the urine. There's been a long effort, a big effort now to improve it and to make sure that the sensitivity and specificity will be improved as much as it could be used by community healthcare workers. And then, just as the recommendation of the Commission, ultra-portable X-ray. This also are quite very important potential technologies that can be used at that level of that system because they're very easy to perform. And this could be empowered by artificial intelligence, of course. And these are point of care. The next level of that system now is where healthcare facilities are available, which might be a small laboratory and stuff. So currently there, we can imagine that TrueNAT, which is the new technology, molecular technology approved by WHO for TB diagnostics, is a molecular test. The gene expert is already somehow positioned there, at least to collect the samples. And then this level could in fact be also a GP office. In many countries, the private sector is contributing quite a lot to diagnosing and treating TB. And this could be the level that we are talking about at this level of the system. And here I would call this more a point of need test, which could be the GAIA Reach, which we are going to hear very soon, and other potential molecular tests that could be positioned at this level on top of the current TrueNAT. Then we look at district and private laboratory hospital. Then we have the confirmatory for IGRA, the old IGRA, the one that we've been talking until now, the ELISA IGRA, as it were. And then we can have a new molecular test on top of TrueNAT and GeneXpert. In the future, of course, would be very much the same here. We are looking more at new molecular tests with high throughput screening. The other interesting part at regional level, based on what is happening now, is the next generation sequencing, RT-PCR, which is a very important potential, particularly for MDR-TB. And this is how a potential strategic plan for TB could look like in the context of a national essential diagnostic list. And just the last thing I want to say is that at the next ASLM meeting, there will be a full session in November on the essential diagnostic list for Africa. Thank you for your attention.
Thank you, George. I will take over the screen.
Yes, please. So before you do that, or while you do that, I will take this opportunity to introduce you. Dr. Davide Manicero is a medical doctor with a unique mix of expertise, combining clinical and public health experience with medical and clinical affairs leadership roles in both the pharma and diagnostic sectors. His key expertise focuses on aligning diagnostic and drug development with clinical and public health needs. And his area of expertise extends to IVD and antibiotic development, antimicrobial resistance, TB, infectious diseases, and tropical diseases. He also spent quite amazing. He spent over a decade working on TB from the public health side as WHO medical officer in Indonesia, and subsequently as head of the TB respiratory infection at the European CDC. Dr. Manicero is currently the chief medical officer at QIAGEN and maintains his academic interest as honorary senior lecturer in global health at the University College of London. The floor is yours, Davide.
Thank you very much, Giorgio, for the kind introduction and for your very relevant presentation. We really set the tone in introducing what we have been trying to do at QIAGEN to try to shift the way we support TB infection screening and accessing TB prevention in high and intermediate burden country. So the idea in the next 20 minutes is to present the GAIA Reach TB, which is our innovative solution for TB infection screening. You will also know that throughout the presentation, I try to stick to the terms of TB infection. There is a movement in WHO, as you will notice in the most recent guidelines, to sort of step away from the latent TB concept, although I think as a term is still very much valid. Giorgio rightly presented the continuum of infection to disease, and from a biological standpoint, the term TB infection seems to be more applicable these days. Now, Giorgio pointed out on the issue of diagnostics as an essential requirement for universal health coverage, and that is very much welcome. I think all of us have been exposed to case studies over the last 2 decades on how diagnostics were neglected, particularly in key public health programs. I'll cite 2 examples here. The rollout of antiretroviral therapy, which really took time to take off because of the lack of access to HIV testing, as well as CD4 testing. And from the TB standpoint, I think the rollout of MDR-TB treatment took a while to take off because of the lack of readily available and accessible MDR-TB or drug-resistant diagnostic. I think the situation is improving. There is a recognition that the diagnostic play a central role, both from the clinical management point of view and from the population level. But that number that Giorgio highlighted of 47% of the world population still not having access to basic diagnostic, I think is a clear example of the path that we have in front of us to improve diagnostic universal coverage. And I think TB infection care cascade is, or LTBI, if we want to use that word for familiarity, it's a particularly sensible one and prone to delays and loss of opportunities to provide TB prevention because of difficulties from the diagnostic standpoint. I mean, you're probably all very familiar with this type of cascade where you see a leak of opportunities and missed opportunity to have 100% of treatment in those that require TB infection or TB preventive treatment. And you can see in this review from 2016 by Hannah Halsdorf, really only 18% of individuals would complete treatment. And here is really, you can see that about 30% or up to 40 percentage points of individuals are lost for diagnostic related reason, whether lack of access to initial test or lack of receiving results or referral to in case the test is positive. So really the reason are very much diagnostic focused. And I think to go very much to the essential of current approaches and paradigm of TB infection management, what we see today is that a large cohort of patients are actually treated empirically. So before any testing is doing, and if you see WHO particularly early recommendation, which in certain high-risk groups still stand, because of the difficulties in testing and diagnostics, the approach is to offer and provide TB preventive treatment with one of the 5 approved treatment regimen on an empirical basis without a diagnostic guidance. What that is causing is really a low acceptability and really loss to opportunity to provide TB preventive treatment. So this was really important for us at QIAGEN to realize that as we stand nowadays with the IGRA solution, and in our case with Quantiferon Plus, despite the operational characteristic, clearly advantages when you compare to the skin test or other diagnostic approaches, for the high burden, intermediate burden setting, because of a number of technological obstacles, and particularly the requirement for ELISA, still we were not able to put down that barrier to acceptability and access. But really what we want to see, and that's what prompted us to work toward GAIA Reach, which I will give you a summary in a couple of slides, is to move toward a situation where testing is readily available, is accessible, and implementable in low mid-resource setting, so that acceptability and accessibility is increased, and you increase your adherence and the ability to include larger cohort in TB prevention program. I think what is very encouraging is that the environment from a TB global strategy has changed from the day of the Stop TB strategy to the EndTB strategy, and TB prevention is now recognized as a key programmatic pillar in elimination of TB. And therefore, we felt prompted to invest more and find a solution to bring the Quantiferon Plus solution into a friendlier version to be more applicable to a high burden setting. And this is what it looks like. I will go over it in a second, but in essence, what we're talking about, as Giorgio anticipated, is a digital lateral flow based on quantum dot technology. The hub you see here is no other than a simple electricity hub, which is rechargeable, is actually battery operated, so doesn't need essentially a plug-in, so it can be utilized at any point of need. As you will see, we have moved from 4 tubes to 1 single antigen tube, and I will elaborate this. But in essence, the assay is run in these USB stick-like cartridges, which are at the dimension of old-style USB stick. We're talking about 6 to 7 centimeter with a single well where the analyte is introduced, and the reading occurs on the hub. But again, the entire analytical process happens inside the e-stick, these little sticks that are depicted here, and the hub again only acts as a provider of provision of electricity for the assay to run. Now, I just want to give you a quick overview of the history of Quantiferon technology out of interest, and also see how it is evolved. I mean, early in 2001, the first Quantiferon TB, it's important to remember that what this was is it was really placing the tuberculin that we were all familiar with from a skin test format into a liquid format, ELISA-based, and therefore eliminating the subjectivity of the skin test. So what I always say, the first Quantiferon really was simply taking the skin test in a more controlled, objective environment into an ELISA-based assay. But in essence, it was utilizing the same antigen. It was really in 2004 that the big change came with the introduction of a different set of antigen. CFP10 is at 6 and TB 7.7 at the time, which created a clear advantage in terms of specificity compared to the skin test. And that evolved into a 2007 version based on 3 tubes, 1 antigen, and 2 control, a negative and positive control. So a more friendly version with a tube format, much more scalable than the previous version. And then it came in 2014, the Gold Plus, which you're all familiar, and is what is present in the market at the moment, which improved previous version by adding the CD8 antigen detection, fixing some of the sensitivity drawbacks that we had, particularly in immunocompromised, HIV positive, CD4 depleted individual, and adding more stability to results. But again, this was still ELISA-based, and is still ELISA-based, and we have to admit it had very little penetration in those settings with higher burden and less access to centralized laboratory service. And that's where GAIA Reach Quantiferon TB comes into place. Is expected to be launched very soon. It has been CAIBD marked, and the commercial release should occur very soon. The peculiarity of this new version of Quantiferon is, first of all, that it eliminates the requirement for ELISA, and I will show you how that impacts the diagnostic flow. There is no maintenance required. It's a very robust, scalable, and simple to use solution. As I mentioned, it is battery operated with up to 8-hour battery backup. It is digitally run and connected, and that is really important in terms of connection to LIMS and ability to centralize data collection and analysis. There is no cold chain required whatsoever, and as I mentioned, it's highly portable with a weight below 1 kilogram. But let me just compare the actual flow between the conventional Quantiferon Plus based on 4 tubes, which, as you know, requires incubation, to elicit the interferon-gamma response, centrifugation, and then it can be run both with manual ELISA or through one of the automated solution with our collaboration with the authority through the Liaison platform, so a clear automated solution. But you can see here, it's really this dark blue area which has hindered the scalability and the applicability of Quantiferon Plus in lower resource setting. And that's where GAIA Reach come into place. You can see the green line here, first of all, moving from 4 tubes to a single tube. The single tube actually replicates the CD4 CD8 tube. So we chose the tube that provides the maximum sensitivity, and we developed the product in a way that we lose the two controls. Still, we have the requirement of incubation, so that remains a requirement of 16 to 24 hours, 37 degrees centigrade incubation. However, again, it's a low cost, low investment solution which is required. Centrifugation now becomes optional. There is no requirement for centrifugation. Obviously, we mention it as an optional because the pipetting without centrifugation could be prone to hemolysis and artifacts. So it does require more careful approach. But again, centrifugation can be omitted. And obviously, the entire ELISA-driven, whether automated or manual requirement, is then removed, and it goes directly into the application of the digital lateral flow with point-of-care results at the site of need. Now, in terms of performance, because one of the key questions is through this modification, particularly by utilizing a single antigen tube and losing control, how has this impacted the performance? Well, the field will say, field implementation often tells us the full story, but what I'm very happy to share with you are a couple of independent studies and company-driven studies. The first one here you see is the clinical performance study carried out by Fukushima and colleagues in Japan. And this was done in two ways, both in correlating Quantiferon, GAIA Reach Quantiferon TB to the Quantiferon Gold Plus, and calculating agreement between the two, as well as independently comparing these to pulmonary culturally confirmed pulmonary active TB. And you can see here the results were really good with 100% sensitivity vis-a-vis the surrogate with active TB and 97.6 specificity. And when we look at correlation with Quantiferon Plus, extremely high with 98.8% overall concordance with Quantiferon Plus used as a reference standard. This was actually replicated in our internal study, which is the basic study for our PAIBD approval. And you can see with the same approach of concordance between GAIA Reach and Quantiferon Plus, an overall agreement of 97.3% with a PPA of 94 and an NPA of 98.7%. So there are good indication that we are going the direction of at least maintaining a very good level of performance despite having simplified the process. And there are other studies coming up. I would strongly recommend that you keep track of the upcoming abstract at the Union Conference, where some more independent study will be presented, and more are being published, particularly in the European Respiratory Journal. Now, one other key point, which I think is really important if we go back to those initial concepts about diagnostic access, is something that we had not looked in the past, and it's really the usability. And you're all familiar with Zambard, HIV and TB project that has been going on for decades. Within Zambard, there has been an independent usability studies where we've looked, the investigator have looked at effectiveness, efficiencies, and user satisfaction. And you can see, and this has been summarized in a journal article, which can be shared with you, with very high level of effectiveness, with very high level of pass rate for the 4 tasks that identify the process from pre-analytical to the analytical one, and very high level of efficiency, with all tasks completed in less than 1 hour, with a mean of 29 minutes. So immediately you can see the impact this can have on decision-making for initiation of TB prevention. But more importantly, going back to the first slide I presented, in minimizing that loss of adherence, loss of referral for TB prevention, that 40% that was indicating that of loss that was very much diagnostic related. So what are the hopes that we have? Well, first of all, we know that the skin test has for years been the reference standard in high burden setting. How can GAIA Reach complement this? So far, and again, these are numbers to be taken with caution, and still we have paucity in the number of studies that have been concluded, but you can see that so far, when we compare to the new skin tests like CTB, DiaSkin, and the EC skin test from a sensitivity standpoint, we really maintain that advantage that we've seen for decades in Quantiferon. Same with the specificity, that it doesn't come as a surprise. So that I think is something that we hope to see further corroborated in field-based studies as these are expanded. And more importantly, as is key, particularly in the scalability potential of GAIA Reach, is to ensure the cost effectiveness in the field. And I think we feel this is very promising. We want to see independent studies from a cost effectiveness point of view. But if you take, for example, the study by Stefan and colleagues here, comparing the cost effectiveness of Quantiferon Plus against the number of skin tests, you can see here that Quantiferon Plus cost effectiveness was pretty much on par with skin test, with a minimal incremental cost of 17.4. But if you think about the reduction in terms of operational aspect, moving from Quantiferon Plus technology to GAIA Reach, we expect this kind of cost effectiveness test exercises to bring GAIA Reach much closer to a level of cost effectiveness, which will allow and enable TB prevention to be scaled up. And I would like to really close on this pyramidal concept, which is something similar to what Giorgio hinted at. I think from a point of view, point 4 and 3, we have, by launching this product, particularly from a clinical performance, we have solid indication that we are maintaining that high level of clinical performance. We know where operational aspects have been improved. We are really hopeful, and we have signaled that cost effectiveness and social impact of GAIA Reach TB within the new pillar of programmatic TB preventive treatment intervention will be fundamental. And we really hope that from the field, from collaboration with you and your institution, particularly where TB prevention needs to be scaled up, we'll see cost effectiveness and social impact evidence accumulating and facilitating the uptake of TB prevention. So I will stop there, and I thank you for your attention, and I guess I can hand over to our chair for any question.
Yeah, thank you very much, Davide. This was really a very exciting presentation. But what is exciting is the fact that things are moving. There are new technologies up there, and really it is very exciting, the whole idea that we could eventually decentralize the screening for LTBI at the lower level of the health system and make it possible to have a broader capacity in screening and treating for LTBI. Now, we had quite few questions going on. I'm sure that I will try to address some of this, and there will be one for you, Davide. Before I pass it to my co-chair, Francis, to give his final comments about the thing, I just want to address two issues that I think are quite important. And one is on the National Essential Diagnostic List. It has been asked whether there are countries in Africa that have already done it. There was yesterday a very interesting seminar organized by WHO and FIND, where the presentation of the first essential drug list in Nigeria has been presented. So Nigeria is the first country that has it. And I encourage those who are interested on two things. First, to look at the WHO website and look at all the publications that have been done there on the preparation for the essential diagnostic list, and also how to move from the idea and how to implement it. There is no yet, the big problem is the implementation, because preparing for the essential national diagnostic list is not easy, but something that can be handled. But the implementation is where there is still need of some more work to be done. So, and then the other thing I want to say about it is that in November there will be a full session on national essential drug list on the ASLM conference, and so I'm sure all of you will be participating, but you will be encouraged to look at it. The other thing I want to address is really, before passing it to Davide, is the sputum in few minutes. There's been a request there about talking about whether is there anything coming on that could allow sputum to be detected with Mycobacterium tuberculosis in few minutes. That would require obviously a molecular test, and which is a little bit more complex exercise. I am sure that there is a lot of things going on from that point of view. And there will be also the new diagnostic working group chaired by FIND at the International Union next week, which you could hook in and really listen about some new exciting opportunities, even though personally, I don't think these are really happening tomorrow morning. For the HIV part of it, somebody asked, the screening for HIV people. Of course, any HIV positive should be screened, first of all, for symptoms. If symptoms are there, then of course they should look at it whether the patient has active TB, and then eventually treated for that. If no symptoms are there, but the patient is HIV positive, there is the possibility to start immediately the treatment for latent TB infection in a high prevalence country. Of course, this is something that national guidelines should be deciding on what exactly to do with it, but is recommended to do, even though one have to say that in many HIV positive patients, there might be some contraindication to start immediately treatment for latent TB infection. But obviously, this would very much be clarified at national level by guidelines. And for you, David, before we pass it to Francis, and I think that all this presentation will be shared in the few days from the ASLM, the final presentation that we have done here. And then for you, Davide, was really a question about how many regulatory approval do you have currently for the new technology, and where it has been done? Where is the regulatory approval status of the technology?
Right. So we have obtained 2 weeks ago the CE-IVD, so the Declaration of Conformity for the CE-IVD under the directive marking. So that gives access to the market that recognize the IVD, but that also is open for us a application and collaboration with WHO and the Global Fund. So we have applied for the ERPD, and we are waiting for a reply on that, with the ultimate goal then to update as well the GDF catalog, and therefore the ability then for countries to access through the GDF catalog. Again, most countries that access the GDF will recognize and actually require a CE-IVD versus an FDA or any of the other regulatory approval. Of course, any high burden country that requires regulatory application locally, we would consider that to facilitate access. But again, we want to work with institutions such as GDF, the Global Fund, and WHO to make sure that we increase access in the speediest way.
Yeah, thank you, Davide. I think, it is almost time now to pass to my co-chair. And before that, let me just say that how grateful we are to the ASLM for having organized this which I think a very interesting discussion that we had in the last 1 hour. And also to say that even though we could not answer many other interesting questions, I'm sure that through the ASLM, we could organize a way that if there are burning questions that you throw out now, we will be able maybe to answer to you more directly. So I pass it to my co-chair, Francis Ocean, thanking him for all the support in organizing this one, together with Anafi from ASLM. And thank you to the ASLM really for putting up this great show. The final word are with you, Francis.
Thank you very much, Giorgio and Davide. Insightful and very, very exciting indeed. Now, before we close it, I needed to have the translator, the interpreter, to get us some 2 questions in French. I think I saw some questions coming through in French. The interpreter, if you could please help us with some 2 questions before we close it. Please go on. We can't hear you. Your mic is unmuted, but we can't hear you. Please go on and ask any 2 questions in French that could be there. Yes, please. And colleagues, we're at the top of the hour. You will give us about 2 minutes kindly so that we can deal with those 2 questions and wrap it up. Thank you very much. So interpreter, if you're there, please go on. Okay, so for the French colleagues, sorry, then we will have the questions that are not answered shared with Davide and Giorgio, and that will form part of the materials that we'll be sharing with you as and when they become available. Again, thank you so much for being part of this session. I have to again re-echo that the slides will be shared on mail, but also they will be on our resource center, the online resource center, plus the YouTube channel, plus the recording for this session. We also have the ASLM 2021 conference coming up in November. We encourage you to be part of this. And my colleague David just posted in the chat room that there are scholarship opportunities that just opened, and please, if you're interested, get to the web address that was shared, and it will also be part of what we'll be sharing with you going forward, so that you can then benefit from the opportunities that are available for you to effectively participate in the ASLM 2021 conference. For those that need documentation of their participation in this call for the last 1 hour, the code for accessing your certificates are displayed on the screen. Please take note of them so that you can then get those records picked out and available to you. Again, thank you very much, Davide. I know you did the parting shots already. I will ask, Giorgio did, but let me ask Davide to make his last comment in about 30 seconds as we close this.
Oh, thank you very much for this opportunity. I'm delighted that the first public presentation on GAIA Reach was with the African Society for Laboratory Medicine, because that's really the environment and the collaborators we went to work with. It's a long way ahead of us to scale up to be prevention, but we are delighted that at least we can contribute from a diagnostic standpoint. And at QIAGEN, my team is fully open to consider any collaboration that can facilitate the uptake of TB prevention, which we feel is fundamental to progress toward ending TB. Thank you very much again.
Thank you very much. And we'll give Giorgio a standing ovation for the great work he's done, not only in the TB world, but also in a lot of other areas. And I'll ask everyone to open up their mic, their video as we close this. Please open your cameras and wave to Giorgio, a great gentleman who's done great work for not only the continent, but also the globe. Thank you very much, everyone, and wishing you the best day, evening, and night ahead of you. Over from me.
Thank you very much. Thank you.
Thank you.
Thank you. Bye-bye.
Thank you. Thank you. Bye.
Bye-bye. Bye-bye.
Bye. Thank you. Thank you. It was a great moment.
Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye-bye.
It was a great
Bye. Bye.
Good to see you, Giorgio.
Bye.